Good morning. Thank you, Chair. It's an absolute delight and pleasure to be here, and especially to be here on a day when you are recognizing the contributions of John Waterlow. As Joe Millward has said, he is not strong enough to be here, but there's no doubt in my mind that he would have delighted to be here, especially as he has always been most interested in the aspirations of young people and has spent a lifetime looking to see how he can enable and facilitate their work and their progress. My relationship with John Waterlow is through the Tropical Metabolism Research Unit in Kingston, Jamaica, which he established as a medical research council unit in order to understand the pathophysiology of severe malnutrition with the objective of enhancing its improvement. More children die of severe malnutrition than any other condition, and millions die every year because they are inadequately or inappropriately treated. Now, pediatricians, when they engage with children, often start off with a game, and so I'm going to start off with a little game with you. There is a game show on television in the United Kingdom which offers the contestants 4 images and asks them to identify which is the odd one out. And so my 4 images are a fetus, a breastfeeding baby, a severely malnourished child in Jamaica, and a severely malnourished adult in the intensive care unit at Southampton General Hospital where I work. And I ask you to identify which you think is the odd one out, and I just ask you to raise your hand. Who thinks that the severely malnourished adult is the odd one out? Nobody. Who thinks that the severely malnourished child is the odd one out? Ricardo. Who thinks that the breastfed baby is the odd one out? Nobody. Who thinks that the fetus is the odd one out? Does anybody think? Okay, well, maybe, I apologize for not speaking in Spanish, maybe something has been lost in translation. But one of the things about this game is that the most obvious answer is usually the wrong answer. And so if you take the 2 severely malnourished individuals, whether they're in Jamaica or in Southampton, they are both undergone a process of adaptation, reductive adaptation, and they have a challenging metabolic state, and if they are fed with generous amounts of protein, then they are likely to deteriorate and may well die. And therefore they need a low protein diet. The breastfed infant is being fed on the lowest protein intake that you have at any stage of your life, and yet grows at a faster rate than any stage at any time in your life. And so on a very low protein intake, it grows very, very rapidly. The fetus actually receives effectively a very high protein intake, a high amino acid intake from its mother, and grows very well on a high protein intake. However, if the mother herself is given a high protein intake, then there is a danger that the fetus will grow more slowly. And so it is a complex situation, but 3 of the images, the breastfeeding baby, the 2 malnourished individuals, will do worse on a higher protein intake. The fetus does better on the high protein intake, provided the high protein intake isn't given to the mother. And so these very obvious everyday experiences help us to recognize the complexities of some of the issues that Joe has been talking about, and to think about what it is that we need to know as well as what it is that we do know. Now, as I said, John Waterlow set up the unit in Jamaica, the Tropical Metabolism Research Unit, and the objective there was to do science-based experiments and to apply that science to care in order to improve the outlook for severely malnourished children. And this graph shows a plot of the mortality rate each year from the start of the unit, the inception of the unit, over time. And you can see that the very early studies on potassium and magnesium enabled interventions which reduced the mortality from something like 60% down to as low as 5 or 7%. And then suddenly, around 1973-74, there was a substantial increase in mortality. I'm sorry to have to tell you that I arrived to look after the children in 1973. I arrived from England, from London, where I'd been trained as a pediatrician, and I was good. At least I thought I was good. I could do everything that pediatricians needed to do, and I thought I could look after babies. And I went to this unit, and I treated the children in the same way as I treated children in London, and they started to die. And at the end of the year, I went back to London, and I met with my professors, and I said, "Professors, thank you for the training, but I have to tell you, when I apply that training to malnourished children, they die. There is something different about malnourished children, and they have to be treated differently." And so the approach to this child has to be different to the approach to normal children. And so the first important lesson I learnt within the framework of John Waterlow's field of influence was that severely malnourished children are different, and mortality is increased if they are treated like other children. And of course that raises the question, well, why should they be different? What is it that you ought to do? And that's really why John Waterlow set up the unit, and that was one of his lifelong ambitions. And perhaps some of that difference is captured in the words that we've used to describe this condition, because originally it was called protein malnutrition, because quite clearly that child that you saw has lost protein. There is a deficiency of protein in the body. But the fact that it has lost protein doesn't necessarily mean that you give it protein in order to cure it, or give it large amounts of protein. There was then a recognition that energy was equally important, and so the term protein energy malnutrition came to be used. And more recently, we've recognized that it's more complex still, and so we use the term severe malnutrition. Clearly, the child is protein depleted, but that doesn't necessarily mean that it has had a dietary protein deficiency, because in order to maintain body protein requires energy. As Professor Millward has said, it requires an appropriate balance of amino acids, and perhaps most importantly, it requires an adequate micronutrient status. And you can't hold on to protein in the body if you don't have enough energy. You can't hold on to protein in the body if you are micronutrient deficient, and therefore you become protein depleted, not because you have insufficient protein in the diet, but because you are not able to hold on to the protein that you're given. Importantly, infection or stress increases the likelihood of nutrient losses, and therefore increases the likelihood that you are not able to hold on to protein in the body. We do use structure anthropometry, the extent to which there is loss of muscle, loss of fat, changes in anthropometry, to characterize malnourished individuals. And we assume that that change in anthropometry, that change in structure, marks faithfully a change in function. And so the tendency is, if you see somebody that is thin, to give them food to repair the thinness. But in severe malnutrition, function is not reliably reflected in structure, and it's important to correct the function before you correct the structure. Structure is about lean, adipose tissue and bone, but function is about cellular nutrients, the amounts and proportions of nutrients that are within the cell to enable the cell to function normally and appropriately. And therefore the first concern for severely malnourished children is to repair the cellular function, repair cellular nutrients, so it is then able to utilize energy and protein in the diet to make tissue, to repair the tissue that has been lost. And in order to carry forward this understanding and better manage children around the world, Ricardo Uauy, as President of the International Union of Nutritional Sciences, together with the International Pediatric Association, has formed the International Task Force on Malnutrition in 2005, with involvement with the World Health Organization, United Nations Children's Fund, and the International Atomic Energy Authority. And on the website of the ITMF, which is given there, there are details that explain what these processes are that lead to risk of death in malnourished children and how best to go about treatment. And much of that is a direct legacy of the efforts and insights that John Waterlow brought to the condition. And so we have problems across societies in development, children at all stages in developing countries. For most of the children in society, they may be issues of food security, which is very much about the quality or nutrient content of food as the amount. Children who start to become undernourished, get mild to moderate malnutrition and stunting, require supplementary feeding, and those who become sufficiently severely malnourished require therapeutic feeding. There is a small group of children, the sort that I've been showing you and describing, who are severely malnourished with complications, and they need special care in a facility, and it is that special care, the understanding of that special care, generated by the sort of work that John Waterlow encouraged, that enable us to better understand not only how to treat severely malnourished children, but also mild to moderately malnourished children, and give us a clear indication as to what food security should be for many populations around the world. And so that approach has been captured by the World Health Organization in their recommendations and documents, and if malnourished children are looked at through a nutritional lens, then effective care is counterintuitive. And so when I first went to the Caribbean, if I had appreciated that, then the children would not have been at risk with my presumed competence. The important point is that structure no longer adequately marks function, because there is this process of reductive adaptation with specific nutrient deficiencies, silent infections, and there is a 10-point structured care program that the World Health Organization offers, 10 points, one for each finger of your hand. You hold the 10 points, you put your hands in your pocket, you've got them safe. And we know that if in even the most under-resourced areas, those 10 points are followed, then mortality from severe malnutrition can fall from 30, 40, 50% case fatality to less than 5%. And in Latin America, in the Caribbean, in sub-Saharan Africa, and in Southeast Asia, we have very clear examples of how, by putting the 10 points into practice, mortality can be significantly and substantially reduced. And so there is a general principle here: the younger, the smaller the child, the greater the vulnerability. And if you take this 1,000 gram at birth baby, then it's mainly made up of protein and water, lean tissue, apart from the brain, which Ricardo is an authority on. It is essentially water and protein. And one of the questions is, how does it go about building up its protein, and are there any constraints on its growth in terms of lean tissue growth? And one of the questions that we started to ask many years ago by using stable isotopes was, how much protein does a baby like that need in the diet, and how much protein does it synthesize? And in order to do that, a very straightforward approach is used, where a labeled isotope such as 15N-glycine is given, and you look to see the proportion of the label that comes out in urine, because the proportion that is retained in the body tells you the rate at which body protein is being made. And surprisingly, when we did that in small preterm babies, we found that we didn't get any of the label from 15N-glycine in the urine, that it was all retained within the body protein. And the fact that the label was effectively retained and there was no flow to urea told us, or suggested very strongly, that this simple amino acid, which is usually considered to be non-essential, can readily be made in the body, was being held onto very strongly by the newborn baby, and therefore was acting as we would expect an essential amino acid to act. And when we look to see, well, just how much glycine does the baby require, and look to other studies carried out by Elsie Widdowson and her group, and this slide shows the amino acids down the left-hand side and the millimoles required along the x-axis, and you can see that there is a group at the top in red, which are the non-essential amino acids, And they tend to be required in greater amounts than the essential amino acids, a little bit like the slide that Joe showed you of the amino acid concentrations in muscle pool. But what you see is the amino acid that is required in substantially greater amounts than any other is glycine. It's required twice as much as the next amino acid, glutamate, and required substantially more than any of the essential amino acids. And it was quite clear that for this preterm baby, when we were giving the 15N-glycine, it was being sucked up and drawn into the body with none to spare to go to excretion. And so it was quite clear that during growth, the demands for this simple, non-essential amino acid was very high. The ability of the body to make sufficient to meet the needs of the body was not adequate, certainly in the preterm baby. And that made glycine a conditionally essential amino acid, an amino acid that could not be made in sufficient quantities in the body to meet the needs. And importantly, one of the factors that determines how much glycine you can make is the status in terms of micronutrients. And if you don't have good micronutrient status, then you can't make sufficient glycine. If you can't make sufficient glycine, then that's a challenge for growth. Because we can look at the sorts of things that glycine is used for. Being a simple amino acid, it's a building block for a number of processes. So structurally, it's required for the formation of DNA and RNA. It's required for collagen formation. Every third amino acid in collagen is glycine, and therefore if you're going to make bone and grow longer or taller, you need substantial amounts of glycine. It's used in a functional sense in a way that other amino acids aren't. So it's required for heme formation, it's required for creatine formation, it's required for bile salts for the absorption of fat, and it's importantly involved in neurotransmission. But it's also required in cellular protection. It's required for glutathione formation, it's required for excreting xenobiotics, and it has a particular role in protecting cells from anoxia. And so extraordinary amounts of glycine are required for all these functions, although relatively little is provided in the diet. We developed a simple method for assessing the glycine state of the body based upon the urinary excretion of this compound 5-oxoproline. And this slide simply shows you that if you take pregnant women who are carrying a fetus that needs glycine, and the mother has to provide the wherewithal for that glycine, that as pregnancy advances, the excretion of this product in urine increases, suggesting that the mother's ability to provide sufficient glycine to the offspring is being strained and stressed. And therefore, in this situation, glycine is conditionally essential, and the question is, what is limiting its formation? And we know that the formation of glycine is dependent, for example, on folic acid, B12, riboflavin, pyridoxine, sulfhydryl status. These other nutrients are required in order to enable protein metabolism. And there's a range of situations where we have found that the availability of glycine is constrained based upon the increased excretion of 5-oxoproline in urine. So that in all the growth situations we've looked at, pregnancy, infants, and during catch-up growth, there is an increase in urinary 5-oxoproline, suggesting that growth places a particular strain on the availability of glycine. In pathological situations, burns or sickle cell disease, when red cell turnover is increased, there is an increased strain on the availability of glycine. And in some of the chronic diseases, asthma, diabetes, and hypertension, there is also evidence of a limited availability of glycine. And therefore we know that the need for glycine is 5 to 10 times the dietary intake. Therefore the need for synthesis in the body is very high, and synthesis requires good micronutrient status. If I then move to the other side, from the synthetic side to the oxidation side, Professor Millward has already talked about the oxidation of amino acids, and I want to look at that a little more deeply, particularly in terms of urea nitrogen. So amino acid oxidation gives energy and urea, and in the normal adult, something like 15 to 20% of energy normally comes from amino acid oxidation. In the fetus, as I have said, the amino acid requirements are high, and part of the reason for high amino acid requirements are because the fetus uses amino acid oxidation as an important source of energy, something like 30 to 40% of its energy. And as I've already indicated, only 7 or 8% of energy is derived from protein in breast milk. And so there is an apparent mismatch in the newborn between what is required and what is being provided in the breast milk. And the answer to that comes through a greater understanding, again, using stable isotopic probes, as to how urea, which is normally thought of as an end product of metabolism, is in fact handled in the body, and how a change in the handling of urea in the body is an important part of the adaptive response to low-protein diets. And so urea is synthesized in the liver, as every decent biochemist and medical student knows, and for an adult on a normal omnivore diet, most of that urea, but not all of that urea, 65%, is excreted into the urine through the kidney. As a normal matter of course, a third of the urea produced passes to the colon, where it is used as a source of nitrogen by the microflora in the colon, and the microflora make amino acids out of that, and those amino acids are available to the host for its own metabolic requirements. In individuals who are on a low-protein diet, or where the requirements for protein increase because of growth, or as in pregnancy or childhood, the proportion of the urea that is produced, that is excreted in the kidney, is reduced to as much as 35%, and a much greater proportion passes to the colon and is used by the microflora for the synthesis of amino acids for the host, which can be used by the host. In the breastfed newborn infant, only 20% of the urea formed passes to the kidney and is lost in the urine, and 80% goes to the colon and is salvaged and is made available to the baby in the form of urea, in the form of amino acids. And so although the baby is on a low protein intake, the baby can utilize that nitrogen with very great efficiency by salvaging the urea nitrogen, passing it to the colon, where the bugs, the microorganisms, make amino acids that are then available to the host. And we know from molecular studies that this is a regulated response, and that on a low-protein diet, there is synthesis and upregulation of urea transporters in the collecting duct of the kidney, so that urea in the urine is reabsorbed into the body. Those same transporters are upregulated in the colon, so the urea that is retained in the body is actively secreted into the colon, where it is made available to the microflora, and that this pattern of behavior is responsive to the amount of protein in the diet. And so amino acid oxidation is associated with urea synthesis, but urea synthesis also is related to urea nitrogen salvage, and that urea nitrogen salvage enables important endogenous amino acid synthesis through a symbiotic relationship with the colonic microflora. And so that if we go back to this relationship between amino acid oxidation and the overall status of the individual, and we look at the newborn breastfed infant at the bottom, although breast milk only contains 7 or 8% of energy from protein, the newborn breastfed infant actually derives something like 30 to 40% of its energy from amino acid oxidation, and in that sense is not substantially different from the late fetus. And so when I ask the question, of course, at one level it's a very simple question, and the answer is maybe counterintuitive. At a deeper level, it's a much more complex question, and it calls on us to understand in a much deeper way not just how much protein is required in the diet, but how the amino acids that are provided in the diet are or are not sufficient for the body's need, and the extent to which we have to make amino acids for ourselves, not only through normal metabolic pathways, but perhaps through a symbiotic relationship with our colonic microflora, and the extent to which those amino acids then help to meet or satisfy the need from one condition to another. And that better helps us to understand why in the severely malnourished individual, giving low levels of protein is desirable and helpful and recommended, giving higher levels of protein may be injurious, not because protein in itself is bad for you, but if you give protein that you cannot metabolize and use effectively, then that has potential for harm. And so we have to think about protein not only in its own right, but in the broader context of the nutritional requirements of the individual. Quite clearly, in order to grow, requires energy, and the deposition of lean and adipose tissue is a question of how the macronutrients taken in the diet are utilized effectively for one tissue or another. But that pattern of macronutrient partitioning of macronutrients is absolutely dependent upon micronutrient status, because macronutrient handling and the pattern of nutrient partitioning, the net tissue deposition and functional competence requires that we have adequate micronutrient status. And so over my lifetime, the fashions in treating severely malnourished children have moved from a focus on protein to a focus on energy, to a recognition of the need for energy and protein, to an appreciation that you can't use either energy or protein wisely or effectively unless your micronutrient status is secure and well managed. And it's not that one or other of these is more or less important. It's that all of them are required together, and competent nutrition is about appreciating how each of those goes together appropriately for the context under consideration. Thank you very much.